was a valiant effort. Why not? Because Microsoft Teams does not allow for screen sharing if you're using your I'll give you a go. It's last one. Good.
Plus, minus.
All right, good afternoon, everyone. Sorry for the delay. So we're going to get started. All right, how's everyone doing? Good? I'm going to turn the displays on here. Thank you for reminding me. There we go. Give them 1 second. Boom. How's that? A lot better. All right, so what we're going to start covering today is the abdomen. We're going to move into the abdominal cavity, viscera a little bit by the end of the week. What I will say is that we're going to get a really good break from muscle attachments. Hooray, right? But then also we are going to have some content that maybe is a little unfamiliar, some terminology that maybe it's a little unfamiliar as well. My advice, take a deep breath, realize it's going to be okay, and try to absorb it and learn it as well as you can. And for me personally, drawing it out and drawing it out and drawing it out over and over again really does help. So the first thing we're going to cover is going to be the diaphragm. Let me hit the lights here so you guys can see it better. Is that better? Sweet. What's that? Yep. That's what the little red dot on there is. Yeah, understood. Thank you, appreciate it. So first thing we're going to cover is the diaphragm. Now, diaphragm is one huge muscle with a huge central tendon, but two different sources of innervation. So this is going to be one of the very few times in the human body that we cover a muscle that has two different sources of innervation. Okay, now we're going to see this in other places. For example, last semester you guys saw pec major, right? Everyone remembers what pec major innervation is, right? Medial and lateral pectoral nerves. I have two nerves going to one muscle. The diaphragm is a very similar concept to that. So essentially what the diaphragm is this huge kind of umbrella of a muscle. Now, what we have to understand is that, like I said, I'm going to have a huge central tendon here. So from here all the way over to about here, this is all tendon, and it's going to be called the central tendon. On the lateral aspects, both right and left, I'm going to have muscle. Now, the reason for that, and this actually is kind of important to understand and realize, is if I have a tendon, is that contractile tissue or non-contractile tissue? Non-contractile tissue. Why do you think it's important for the central portion of the diaphragm to be made up of non-contractile tissue? Support, okay, I got support, I got vasculature, okay. As we can see from the picture over here on the right-hand side, so this guy over here, look at that huge structure, look at that huge structure. I also have my esophagus that runs through there. So I have some pretty major things, some pretty major structures that I need to get from the top half of my body down to the lower half of my body. If we think about it, if I have a muscle in the central part of my tendon, what's a muscle do? Muscles are kind of dumb. They contract. That's all they do is contract. Could you imagine if my diaphragm contracted in the center, what would happen to my inferior vena cava, my aorta, and my esophagus? They'd all clamp, wouldn't they? So this is actually kind of a nifty mechanism, in my opinion, that we have this huge muscle, but we have a tendon in the middle of it in order to support those structures by way of letting them do their job, right? So the diaphragm kind of in the middle, in the central tendon kind of says, okay, esophagus and aorta and IVC, you guys do what you got to do. We're just going to provide support around the edges. So like I said, personally, I think that's kind of a neat aspect of it. There's going to be two major hiatuses, okay? And do you guys know what a hiatus means? It's a break, exactly, right? So, you know, if you have a couple folks in a relationship, they're on hiatus if things go wrong, right? So I'm going to have two major hiatuses here. I'm going to have a hiatus for my esophagus, and I'm going to have a hiatus for my aorta. So this is going to be my aortic hiatus. And this is going to be my esophageal hiatus. Now understand that even though I'm drawing them a little apart, they are literally right next to one another. And what's really nice in terms of cadaver dissection is that you can really see these. Like you can actually get in there without doing a whole lot of dissection, and you can go, oh, that's the aorta. I can see it going through the diaphragm. Oh, that's the esophagus. I can see that going through the diaphragm. Now, the aortic hiatus is going to happen right about T12. So my aortic hiatus is going to happen right about T12. My esophageal hiatus is going to happen just a little bit higher than that, and it's going to happen right at T10. Now, these become very important because there is a condition out there, and it is a condition that I will say I have seen personally in an outpatient clinic. Someone comes to me with a diagnosis of a hiatal hernia. Okay, I'm going to write that down, a hiatal hernia. So are you guys familiar with what a hernia is? Okay, so there are a couple different types of hernias out there, right? So I can have an inguinal hernia, right? We commonly see that with sports and with heavy lifting, and that is a hernia. Yes, ma'am. Please. What thing isn't working? The blue button. That's because I'm on Teams.
Oh, okay.
Yeah. So you can either FaceTime her, or she can do Teams, or you can do both.
Okay.
Yes. Actually, what I would suggest doing is have Teams coming through the left ear, FaceTime coming through the right ear, so that way I'm in stereo. Or I'll take it back to Dr. Justice and I's day. We could have a quadraphonic going on. Oh yeah, throw an 8-track in that bad boy, it's a good time. Yes, yes. I'm thinking REO Speedwagon would be a good one.
I was just telling my kids the other day, one of my friends needed just an 8-track player in it. And it was actually rumors. 8-track was in the glove box when I bought that truck.
Oh, that's awesome.
I wore that thing.
That's a good album.
Yeah. Sorry.
No, you're good. We're good?
Yeah.
Okay. So when my patient has a hiatal hernia, what do you guys think is happening? So exactly. One of those hiatuses, one of those openings, has become bigger than what it's supposed to. Now, what we're going to learn as one of the major functions of the abdominal cavity and the abdominal muscle is to compress the organs, to keep them where they're supposed to be. Also, my abdominal muscles increase abdominal pressure. And we know that, right? If I do a sit-up, I can feel everything kind of getting tight and kind of squished down here. If I cough, I feel the same thing, right? So, right, I cough, I can feel my abdominal muscles pushing in on my viscera. If we think about it, if I have a hole in my diaphragm, what direction are my abdominal organs going to go? They're going to go up. And in fact, in diagnostic imaging last week, I showed the students a picture of a radiograph. And literally what you saw was the heart, and then you saw this big ball right on top of the diaphragm. And that big ball was the stomach. And it sounds ridiculous, but what happens is that these folks come in and they say, well, I'm doing okay until I need to exert myself, right? So this is kind of where the anatomy needs to function a little bit in this course. Think about activities that folks would have trouble with that if they had a diagnosis of a hiatal hernia. So what's the first thing you guys do when you get up in the morning? You sit up, right? So when I sit up, okay, who said hit their phone? Okay, that's fair, right? Hit TikTok, whatever you got to do. Then at some point you get up, right? So when you transfer supine to sit, I'm going to contract my abdominal muscles, my rectus abdominis and external abdominal oblique and internal abdominal oblique muscles we're going to get to. That's going to increase abdominal pressure. If I have a hiatal hernia, I will experience pain when that activity happens. Does that make sense? So these are the questions you need to ask your patient. Not just, hey, where does it hurt? They're going to say, oh, yeah, it kind of hurts in this area here. Guaranteed they're going to go to primary care and they're going to say, you have acid reflux, or you probably ate something wrong. You know, here's some omeprazole or something like that. You need to take the next step and say, tell me exactly what activities cause your pain. You guys are going to get into this in MSK1. What are my ags and what are my eases? What are my aggravating actions? What makes it worse? What makes it better? If my patient's telling me a bunch of things that increase abdominal pressure, there's a possibility they have a hiatal hernia. Okay, so this is why you kind of need to know this stuff. Any questions on that? Okay. All right, so when we get into abdominal contents, there's a couple different ways to dice up the abdomen. Okay, so this is a very superficial view here. There's a 9-box system and there's a 4-box system. What we're going to do is we're going to use the 4-box system in this class. Why? Because it's the most commonly used clinically. If you want to go get a PhD in anatomy, go right ahead, you'll learn the 9-box system there. But if I take the abdomen, I'm going to split it into 4 different quadrants. Now realize these quadrants are going to be in anatomic position. Okay, remember very first class anatomy, anatomic position being this position here. I'm going to have a right upper quadrant. I'm going to have a left upper quadrant. I'm obviously then going to have a right lower quadrant. And then I'll have a left lower quadrant. So the big things I need to understand here in terms of viscera is where everything's located. This will help out a bunch when we start drawing the blood supply to the abdomen and the viscera. If I kind of know where everything is located, then in terms of like branching, because what we're going to see is there are going to be a ton of branches coming off like the celiac trunk and the superior mesenteric artery and inferior mesenteric artery. If I kind of know where everything's located, I got a gambler's chance at getting those questions right. So in the right upper quadrant, I'm going to have 2 big structures here. I'm going to have my liver, and understand that anything that involves the liver is going to have the prefix hepa. So hepatic. So what we're going to learn about is maybe like the hepatic artery. So the hepatic artery would be the artery that goes to the liver. The other big one I'm going to see here in the upper right quadrant is going to be my gallbladder. And the gallbladder has the prefix cyst. So if I'm in, yes, ma'am.
I was just going to ask, where does the quadrants like start? Like where?
So that's a good question. So the midline, this is going to be basically the midline of my abdomen. And then this is basically going to be my umbilicus. Good questions.
Thank you.
No worries, no worries. So anything that has cyst, so if I'm an acute care therapist, I go in, I look at the chart, and my patient has had a cholecystectomy. A cholecystectomy is going to be the removal, ectomy, of the gallbladder, the cyst. Okay? If they have cystitis or cholecystitis, that means they have inflammation of their gallbladder. My left upper quadrant is going to have 3 basic structures. 2 of them are going to sit super close to the midline. So what I'm going to draw it out here is we're going to have our stomach, which is super close to the midline, and my pancreas is super close to the midline. Pancreas does not have an E. Way over here on the left side is going to be, wow, I'm really not writing well today. It's going to be my spleen. So in terms of prefixes for stomach, pancreas, spleen, the pancreas one is kind of easy. It's literally pancreo. The stomach is going to be gastro. So if you guys are familiar with kind of the new age restaurant, a gastropub, that's literally what it means. It means stomach pub. That's kind of gross. I hope it comes with some of them. They need a stomach pump to go along with the stomach rub. Get it? But, you know, it is what it is, right? And then the spleen is really easy because anything that says splenic is going to be involved with the spleen. So right upper quadrant, I have my liver, I have my gallbladder. Left upper quadrant, stomach and pancreas sit super close to the midline. Spleen is a little more off to the left on the lateral side. My right lower quadrant, this is the big one, okay? My appendix. I'm also going to see my cecum over here. Those are the big ones. For my left lower quadrant, my sigmoid colon. Now, I realize the word sigmoid just means squiggly. That's all sigmoid means. So the sigmoid colon is going to be that section of colon when you guys dissect it out, it literally is going to go in this nice big S shape. What we're also going to see, and we'll get into this here in a couple lectures, is that the splenic artery is super duper easy to identify because it is also sigmoidal. So the splenic artery is a really nice, easy point to get on a lab exam because it literally does this little like S-curve thing. So if you see this artery that does this little S-curve thing, again, you got a gambler's chance. It's probably splenic artery. In addition to all this, and I'm not going to draw this part in, obviously my small intestine is in here, my large intestine, which is also called my colon, and then all the little pieces and parts like the pyloric sphincter and all the rest of that stuff. We'll get into that a little bit later, but I just want to kind of give you an overview, if you will. I'll hold that up there for about another couple minutes, and then we're going to move on to the abdominal muscles. If anybody has a six-pack, I don't want to see it. Yes?
Why are the errors that you use have the same two umbilicus?
Simply, that's the midline where the umbilicus is. I just drew arrows just to be artistic. Yeah, so the umbilicus, to be perfectly technical here, is right there. So that's literally just saying that that line, just like you would do in math, it goes on and extends. try to sprinkle a little bit of Dr. Fox in this class. How's it going? It's not good, not going well? Not good? No. Everyone having like little like shakes and stuff and like tricking and all that? It's easy. It's easy. Trig is easy. Anything that involves gravity is sine. Anything that involves horizontal is cosine. Done. I just did biomechanics. What's that? What's that? Yeah. Sine is always involving gravity because it's always going to involve the y coordinate. Cosine is always going to involve the x coordinate. Well, on the other side of the graph, then here's what you do. No offense. Negative. Yeah, that's. Oh, conversely just means flip it. Yeah, flip it. It's like Harry Truman. When Harry Truman was president, he said, I want to hire a one-armed economist because every economist would say, well, on the other hand.
Yeah.
So there's your dad joke and a little bit of history. Is everybody good with this picture? Anyone not good with this picture? You got thumbs up that you're good. Okay, awesome. All right, so the next thing we're going to do here is we're going to do the abdominal wall. Now, the easy thing about the abdominal wall is that we only got 3 different muscles. Sorry, 4. We got 4 different muscles. Not a big deal. The easy thing also with the abdominal wall is that all the muscles are super duper big and super easy to identify. Right? We like that. Here's the hard thing about the abdominal wall. What we are going to see is that based on the striation of the muscle fiber, in other words, the direction the muscle fiber is going, that's going to dictate what that muscle can do. Okay? What I'm going to ask you to do is, with this information, take a big step back and practice some of these motions. Because what we're going to see is the difference between internal abdominal oblique and external abdominal oblique. Those muscles do the same for some motions, different for other motions. Okay, and it's kind of the same type of concept like sternocleidomastoid, where it does same side bending, opposite side rotation. External abdominal oblique is going to do the same thing. It's going to do same side bending, opposite side rotation. But then internal abdominal oblique does same side bend, same side rotation. Confused? Me too. Why is it set up that way? You got me. I think it's like kind of like the duckbill platypus is kind of like, figure that one out, right? All right, so here's what we're going to do. We're going to draw out the end of the sternum, the very, very distal edge of the sternum. I'm also going to draw in the xiphoid process. And then we're going to draw in the costal cartilage just as a reference point. Okay. The first structure we're going to draw in here is we're going to draw the linea alba. That looks terrible, doesn't it? You can say it looks terrible. You can say, hey, come on, Kondo, redo that one. Redo that one. Come on. Low effort. Yeah.
You said that was the cartilage?
Yeah, this is the costal cartilage. That's better. Not great, but it's better. So this midline structure is my linea alba. This one's going to be super duper important because linea alba is going to be where a lot of this muscle attaches into. It is literally a big band of fascia and connective tissue. We're going to draw in a little bit of the pelvis here to kind of orient you guys a little bit to the pelvis. This darkened structure down here at the bottom is going to be my pubic symphysis. And my pubic symphysis is going to be all cartilage. So this is going to be my pubic symphysis. Symph literally just means together. So if I go to a symphony, it's a bunch of instruments playing together. Symphysis is just literally two pieces coming together. That's all it means. I'm also going to draw on a little bit of the pelvis on both sides here. So with my pelvis, I'm going to have an opening on both sides, and we know the word opening is foramen. OF is going to equal obturator foramen. I'm going to have two rami on my pelvis. I'm going to have a superior pubic ramus, because this is my pubic bone. And if I got a superior one, you better believe I got an inferior pubic ramus as well. The other big landmark I'm going to draw in here is going to be a landmark that you guys probably covered briefly in tests and measures as a way to kind of check posture, check different fun stuff. And this guy here is my ASIS. Is that term familiar to you guys? Okay, cool. So anterior superior iliac spine, obviously. Now what we're going to see here is that from my anterior superior iliac spine down to my pubic tubercle, the pubic tubercle kind of sits right about here. I'm going to have a structure, and we're going to get into this a little later when we cover the inguinal canal. This is going to be my inguinal ligament. Now what we're going to learn is that the inguinal ligament, and I think Grace has a wonderful picture of this, the inguinal ligament is actually the free edge of external abdominal oblique. This is going to sound really weird until we make the inguinal canal, because we're going to draw that one out as well. But external abdominal oblique, if you look at Gray's, there's this little section at the bottom third where it just kind of like flaps in the breeze. Where it flaps in the breeze and creates an opening for structures like my spermatic cord, or the round ligament of the uterus, or my genitofemoral nerve. That's really where external abdominal oblique doesn't really, for that section, it doesn't really attach to much of anything. It's a free edge because it needs some space, because I need to get certain structures from my abdomen, my pelvis, down to the lower section of the pelvis. Things like my testicles as they drop, as I develop as a person. So what we're going to do is we're actually going to draw in first the easy one in terms of abdominal muscle, and that's going to be the six-pack guy. That's going to be my rectus abdominis. Now rectus abdominis is going to come off of the pubic crest, pubic tubercle, pubic symphysis. So it kind of does this number. And it has these little sections of tendon and ligaments attachment. So it makes these little pockets of muscle, and that's what gives that kind of six-pack appearance. So this guy here is going to be my rectus abdominis. So rectus abdominis is going to be in that blue, we'll call it periwinkle color. What we're going to see as well is that I'm going to have 3 overlapping layers of muscle that literally are going to take a different tangent to one another. The deepest one is going to be the transverse abdominis. And you'll be able to see transverse abdominis because it literally is going to have these very transverse fibers. So transverse abdominis or transversus abdominis, it says what it is what it says. It is the transversely oriented muscle of the abdomen. That's literally all it means. So when the original anatomists looked at it and went, well, it's kind of going in the transverse plane. Well, where is it? Well, it looks like it's in the abdomen. Why don't we call it transverse abdominis? They're like, sweet, check it off the list. What we will see, however, is that once we get below a structure called the arcuate line, and I'm going to write that one down for you guys, okay? So there's going to be something called the arcuate line. I'll write it down a different color so it stands out. The arcuate line is literally halfway in between the umbilicus and the pubic symphysis. And the arcuate line is super important because this is another one, kind of says what it does what it says. What we're actually going to start seeing is transverse abdominis and internal abdominal oblique are going to do exactly what you could think the arcuate line means. What do you guys think those muscles are going to start doing? They're going to start arcing. Arcuate means that's the spot I see arcing happen. And what we actually see is that towards the lower third of transverse abdominis, it starts doing this number. Internal abdominal oblique will do the same thing because what transverse abdominis is going to do and internal abdominal oblique is going to do, those muscle fibers are going to start to arc around because they're going to form literally the superior and posterior reinforcement for the inguinal canal. So the way I kind of thought about it when I was kind of looking at this material is if you can imagine the inguinal canal being this pen, my internal abdominal oblique and my transverse abdominis are literally going to curl around. Okay, so they form a hood posteriorly and superiorly. But as you can see, if I take the inguinal canal out, I still have that space. So that's all they're doing is they're kind of coming up and around, arcing over, still attaching in to structures like the linea alba, pubic crest, pectineal line, all that great stuff that Grace says. But it's not a straight attachment. They kind of do this little arcing motion to create space for the inguinal canal. So we're going to see transverse abdominis do that. We're also going to see internal abdominal oblique do that as well. Now, internal abdominal oblique, what we're going to see is that internal abdominal oblique's muscle fibers are going to be oriented forward and up, anterior superior orientation. So the way I kind of remember it is I stick my fingers on my abdomen. Here's transverse abdominis. My fingers are going straight towards the midline. Cool? Internal abdominal oblique, forward and up. External abdominal oblique, forward and down. Okay? So if you get confused, literally play that, little game, pat your head and rub your stomach. Transverse abdominis, external abdominal oblique, internal abdominal oblique. Okay, that's going to help you a lot on things like test questions, because there's going to be questions, hey, a patient can do this motion, but not this motion. Which muscle was involved? Okay? I mean, you guys are pretty acclimated to the type of questions that are asked in this class, right? That's a very legitimate test question. What I'm going to see is that internal abdominal oblique is, like I said, it's going to be oriented up and in. Anterior superior orientation. The only exception to that is going to be this little fibers, like I said, below the arcuate line, because they're going to arc downward, and they're going to arc in with transverse abdominis. Now the spot, and I'm going to circle this spot and kind of focus on the spot just for a second. The attachment here, where internal abdominal oblique and transverse abdominis arc down, they created that hood for the inguinal canal, and now they're going to attach in to the pubis. You probably saw this in grays, and it's also in netters. Those muscles attach via something called the conjoint tendon. So the conjoint tendon is where transverse abdominis and internal abdominal oblique come together and attach. Okay? So that's something, again, think about potential test questions here. Hey, you had a patient who had a avulsion fracture or a rupture of the conjoint tendon. Which muscles would be involved? Or what are the most likely muscles involved? Right? Think about test questions like that. So when I see the conjoint tendon, I should automatically marry those concepts, TA, IAO. Okay? That's the conjoint tendon. The only other muscle we have here, okay, so we have, the orange color was internal abdominal oblique. The most superficial muscle I'm going to have here is going to be the external abdominal oblique. External abdominal oblique, like I said, orientation of fiber is going to be forward and down, or anterior inferior orientation. And this is where we need to talk about function a little bit. Okay? I want you guys to draw this completely. I'm going to give you a couple minutes, and then for the rest of the time, we're just going to work on, yes, ma'am. Yeah, you're good.
So the external abdominal obliques, they're not going to do the curves?
No, external abdominal oblique does not do the arcing, because the external abdominal oblique, the free edge, is going to form the inguinal ligament. Okay, we mentioned that prior to all this, but I've thrown a little bit in from there. So you're good. Yeah, external abdominal oblique is not going to do this whole arcuate thing. Yeah.
But the internal abdominal obliques do.
Yep. Internal abdominal oblique does the arcing thing, and transverse abdominis does the arcing thing. Yep.
And the external will bypass the conjoint tendon.
External is not part of the conjoint tendon. Now, you kind of know that based on your language, because what's con mean? 2, right? So if it was 3, it would probably be the trijoint tendon, but it's not, it's the conjoint tendon. Make sense? That's why I really try to hit the language, because you kind of understand the language, yeah.
Is the arc of the artificial line, is it an actual line that you can see visibly in the body, or is it just an actual line?
It is an imaginary line, however, where you're going to see the arcuate line, you're actually going to see those fibers start to arc, and they're going to change their orientation pattern. So as soon as you see those fibers change their orientation pattern, you can assume that there's the arcuate line. However, it would be virtually impossible for me to tag the arcuate line on a lab exam. Fair? If I did, then, you know, I'm having a bad day, let's put it that way. Yeah.
It's in between, it's in between the umbilicus and the pubis.
And it goes up and down.
No, it's just literally horizontal. So arcuate line, no, you're fine, that's a good point. So arcuate line is going to be an imaginary line, and I'm going to dot it in here. It's going to be like right there. Does that make better sense? Okay. No worries, no worries. Okay, how are we doing with the drawing? Everybody, is it anyone? Yes.
The arc to make what?
So they're going to make the roof and this posterior reinforcement of the inguinal canal.
And will the 3 muscles, do they stop at the rectus abdominis, or do they kind of go off?
They blend in. Right, so what you're going to see is, and we're going to get into this, we'll probably not hit it today, we'll probably hit it on Monday, is all these muscles are going to have huge layers and sheets of fascia. Okay, and there's, I mean, all sorts of fascia. There's literally something called Camper's fascia, there's Scarpus fascia, there's the parietal fascia, there's the transverse fascia, and then every muscle has fascia as well. And what they do, what you're going to see when you dissect, is you're going to see all this fascia that overlays rectus abdominis. And what's happening is that all those muscles are attaching in, because they eventually all terminate in the linea alba, but they all do it via these sheets of tendon. That's why, I'll be quite honest with you, the stomach and the abdomen is so good for surgery, because they're so thin, you can pierce right through it and do what you got to do.
And that's something you're going to notice as well, particularly among our population of cadaver, if you will, that their abdominal muscles have been super thin. So when you start cutting, recognize that you're probably going to cut multiple layers as you ease that scalpel in. And because those tendons do wind up merging together, you know, you might cut something and feel like, okay, I did a good job with that, I was gentle. You move out just a little bit laterally and recognize, wait a minute, I definitely got 2 layers here. Does that make sense? It's just going to be hard if you cut down the middle to immediately only cut a single layer, because those tendons are all going to run together just like this. So you've got muscle out here, but there's tendons run together like this. So you cut one, what you think is one little layer. Now you're going to have to start pushing your way laterally to try and pull those muscles apart to find those layers of muscle between internal and external abdominal obliques. And then eventually, because of the way things wrap around their internal abdominal oblique and transverse abdominis, you can say that it's just a mass of fascia. So don't think you threw everything up if you wind up moving laterally and say, oh, look, there's multiple layers of muscle here. It'll work out. So, yeah, sorry.
No, you're good, you're good. Everybody good? Anybody not good? Okay. All right, so last thing we're going to kind of cover here is going to be the function of each of these muscles, okay? Really? There we go. All right, so rectus abdominis. This is the easiest one. It's going to do flexion of my trunk, right? So it's going to do trunk flexion. Here's the other one that you need to kind of think about. I'm going to bring back a blast from the past from last semester. It's also going to do lumbar flexion. We see this clinically all the time, right? What's one of the first exercises that you see a therapist do with a low back patient? Let's do transverse abdominis crunches. Let's do something that starts engaging rectus abdominis. When I engage rectus abdominis, two things can happen. I can either bring my rib cage down to my pubic symphysis or my pelvis, or I can bring my pelvis up to my rib cage, right? Both of those are flexing my lumbar spine, okay? So if I want my patient to flex their lumbar spine, I need to have them engage probably rectus abdominis, okay? Now, what we're also going to see is that I have a couple other options to flex the lumbar spine as well and flex the trunk. IAO and EAO, when they contract together, is going to perform trunk flexion, lumbar flexion. And this is kind of where understanding the orientation of these muscles is very key. So we already kind of said that the orientation of EAO is anterior inferior, right? And we already kind of said that the orientation of IAO is anterior superior. As you can see, both of those muscles have the word anterior in them. So because both of these muscles are on an oblique plane, so they're diagonal, they're going to be able to do a couple different things, depending on what else is happening. So if I have two muscles that are both oriented like this, and I contract them both, I'm going to get trunk flexion, right? I have, for EAO, I have something happening in the sagittal plane, and I have something happening in the transverse plane. On the right side, but I also have the same thing on the left side. Now, if we think about this muscle is only going to contract on either side one direction, right? So again, sprinkling in a little Dr. Fox in this class. Now we're going to talk about vectors. So what we can see is that I have one vector going up and down in the sagittal plane. I have another vector traveling one direction in the transverse plane and another direction in the transverse plane. The transverse plane vectors are going to cancel each other out. Okay? Does that make sense? So if the transverse plane left, transverse plane right cancel each other out, I'm simply left with the sagittal plane. So if my left external abdominal oblique and my right external abdominal oblique are both contracting, even though both contract down and in, or anterior, inferior, the only thing I'm going to see if both contract is trunk flexion. Because the transverse plane vectors cancel each other out, simply leaving the sagittal plane vectors. Okay? The same thing is going to happen with internal abdominal oblique. With internal abdominal oblique, same thing. My fibers run anterior, superior, same vectors, sagittal plane, transverse left and transverse right cancel each other out, leaving sagittal plane. So when my internal abdominal oblique left and my internal abdominal oblique right contract, I'm left with pure trunk flexion. Okay? Let's go ahead and let's cut it there. And what we'll do on Monday is we'll get into how these muscles contract when only my left internal and external contract and only my right internal and external contract. And then, as an added bonus, what happens when my only left external contracts and only my left internal contracts. Hooray! All right, have a good weekend, guys. It's really not that bad. You just got to think about what's happening. It's really not that bad. Hey, look. It's because it's not that bad. If I can pass an abdomen, right, and I'm not that bright,